Hi, Adult Health 2. So this is chapter 43. This is thyroid and parathyroid disorders. Here are our objectives. All right. So we're talking about thyroid and parathyroid, but we can't forget that the pituitary gland, which is considered the master gland, the anterior lobe of the pituitary gland is responsible for controlling thyroid hormone by the release of thyroid stimulating hormone. Okay. And that is exactly what thyroid stimulating hormone. It prompts the thyroid to react. Okay. So so when we're talking thyroid and parathyroid, you got to ask, is it related to hormones being released by the thyroid? Is something really wrong with the thyroid and or the parathyroid? Or is something ultimately wrong with the pituitary gland, which is then in turn interacting with the thyroid and parathyroid, causing them to not release or release too much of whatever hormone. Okay. So you can't forget that cascade aspect related to the release of these hormones. All right. So, anterior pituitary gland is going to control the release of thyroid stimulating hormone, which is then, if the thyroid is stimulated to act, basically, okay, then it is going to release T3 and T4. So T3 is triiodothyronine and T4 is thyroxine. Okay. So T3 and T4 control metabolic activity and rate. All right. So hold on. I gotta move my slides because I do gotta read this. Um, and then when we are talking about the parathyroid, remember that the parathyroid is in charge of calcium levels, right? So, and the thyroid gland plays a role in this as well. So calcium levels are controlled through release of thyroid calcitonin from the thyroid gland and parathyroid hormone, PTH, from the parathyroid gland. All right. So don't forget, another thing you can't forget is the importance of the parathyroid and thyroid related to calcium levels. Okay. Because if you remember back to fluids and electrolytes, calcium imbalance can have a lot of things that negatively impact the body. All right. All right, so hypothyroidism. All right. So as we talked about in the pituitary PowerPoint, just remember that the signs and symptoms related to like hypothyroidism are going to be the opposite of what we see in hyperthyroidism. That is kind of the beauty of this. Like they really do sit in juxtaposition of each other. Okay. So release of thyroid hormone is under the control of the anterior pituitary gland. Okay. Like we just said. And then the hypothalamus plays a role in that with the secretion of TRH. Disorders affecting either of these structures can result in hypothyroidism. So if something's wrong with the pituitary or if something is wrong with the hypothalamus, you can end up having hypothyroidism. Okay. In the US, hypothyroidism is largely associated with autoimmune disease, thyroid surgery, or radioactive iodine. Um, and radioactive iodine, here we go, radioactive iodine is used in the treatment of hyperthyroidism. So the radioactive iodine actually kills off the thyroid cells so in hyperthyroidism. Because hyperthyroidism, the thyroid is just overreacting, sending off all these hormones. And so we use radioactive iodine to kill, okay, the thyroid, right? So that it can no longer over excrete. But in killing the thyroid, what do we go and do? Now we cause hypothyroidism, right? And all the problems that go along with that. Okay. So, Hashimoto's thyroiditis is the most common type of hypothyroidism, and is caused by an autoimmune response that leads to destruction of the thyroid gland by immunological processes. So, hypothyroidism can also be associated with iodine and tyrosine deficiencies because they are needed for the synthesis of thyroid hormone. And remember, we talked about this with the pituitary as well. People are using all these fancy uniodinized salts, and now we are seeing hypothyroidism related to low iodine, iodine deficiency, because people are no longer using all the time iodinized salt. Isn't that crazy? So go back to your plain old table salt, okay? So iodine or tyrosine deficiencies because they are needed for the synthesis of thyroid hormone, but rarely observed in the US because of iodized salt. There we go. We know that's no longer true, actually. Other causes of primary hypothyroidism include congenital thyroid disorders, autoimmune thyroid destruction, and cancer, thyroid cancer, right? Hypothyroidism is a major cause of goiter. So that's an enlargement of the thyroid gland. There's a picture in your book, figure 43.1. You can see a goiter when people have a goiter. And really in the US, because of the ionized salt, we were not seeing goiters very often anymore. They used to be very, very common. Let's see. Female individuals are affected 7 to 10 times more often than males. Hypothyroidism occurs most often in females between the ages of 30 to 60. Notice that sounds just like our autoimmune disease stuff. The incidence of hypothyroidism, though, does increase with age. So the patho related to hypothyroidism, so decreased metabolism is the biggest thing you see with hypothyroidism. When the thyroid slows down, everything slows down, okay? Everything slows down. You get decreased metabolism. People actually end up with depression, altered level of consciousness to where they just feel fatigued and weak and slow thinking, like everything just ends up slowing down, okay? So primary hypothyroidism develops as a result of a disorder of the thyroid gland itself, whereas we can get secondary hypothyroidism related to the anterior pituitary gland. So basically, we're saying, primary is when it's the thyroid itself. Secondary would be the pituitary. Tertiary is then hypothyroidism related to the hypothalamus. None of that, I mean, it matters. I shouldn't say it doesn't matter because it does matter, because if we have primary hypothyroidism, then we know that the problem is not the pituitary gland. And given that the pituitary gland is responsible for producing so many other hormones, at least we know that those hormones are not being affected, right? So, so best case scenario is we have primary hypothyroidism, where the problem is just the thyroid. Because if we go to the pituitary, we have bigger problems. Okay. So signs and symptoms, hypothyroidism, they call it a hypometabolic state because it's decreased energy, increased sleep, fatigue, weight gain, decreased appetite, crazy susceptibility to cold temperatures. There's also like psychosocial issues related to like depression, lethargy, flat affect. Like it's really crazy. And sometimes, unfortunately, even though hypothyroidism, like we can treat with Synthroid pretty easily, sometimes those psychosocial aspects do not resolve. So we may even do, like, this person may just not be seeing someone related to the endocrine disorder, but a mental health professional might be helpful just because of the depression, the ongoing depression that continues even when we get those thyroid hormones back to within normal limits. Okay. Diagnostics, you're going to look at T3, T4, and TSH. Okay. In primary hypothyroidism, the TSH level is going to be elevated as a result of the feedback system, okay, to the hypothalamus and the pituitary, anterior pituitary. And this is going to be caused by low circulating levels of T3, T4. This again, when I'm like talking about this, I think it is so helpful to draw a diagram of these hormones as we're talking about them, or have a diagram in front of you so that you can see, okay, this is causing this because this is the negative feedback related to this, right? Because I feel like when we just talk through it, it's kind of jumbly, but I'm a visual person that way, so maybe that doesn't work for you. All right. When we have Hashimoto's thyroiditis, we're going to do an evaluation of antithyroid antibodies. Okay. Replacement of thyroid hormone is primary treatment for hypothyroidism. We're going to replace the Synthroid, levothyroxine, right? That is, think about electrolytes. We're low on salt. What do? We replace the salt. We're low on thyroid hormone. What are we going to do? Replace the thyroid hormone. Okay. So think about that. Anytime we're talking something that is high or low, we're going to either replace, which is really the easy solution. And if it's too high, we're going to have to figure out how to stimulate the body to lower that level. Okay. Because thyroid hormone affects metabolism, the medication is to be taken in the morning. You're also supposed to take it about a half an hour before eating. Okay. These regimens, these med regimens are going to be lifelong because once these glands are malfunctioning, it is uncommon for them to return to normal function. Okay. So once somebody's diagnosed with hypothyroidism and they're on Synthroid for life. Like those levels may fluctuate, we may be able to do that, but these treatments are lifelong. So as you can imagine, compliance can be an issue here, right? Also, when we are taking hormones, you're supposed to take hormones at the same time every day and in a manner that most reflects how the body would normally release those hormones. So think about that level of compliance now too, right? You know, not only do you have to take something every single day for the rest of your life, but you need to take it at the same time. Maybe you need to wake up earlier than you normally do so that you can take Synthroid on an empty stomach, right? So compliance is always a thing with these. Hypothyroidism, like we talked about, decreased metabolic state. Hypothyroidism, everything is slowed down. Everything is slowed. Okay. Complications, our complication that we see with hypothyroidism is myxedema. Myxedema may develop. The patient with hypothyroidism may present with social issues. Oh, we talked about that. I apologize. Let's see. All right, we talked about all that. Okay. Complications. Oh, here's our slide on myxedema. I thought I had one. All right. So hypothyroid complication, myxedema. So this is a condition resulting from an increased deposit of glycosaminoglycans, a type of polysaccharide in cells and tissues. So if you look at this picture, okay, this is slide 6. So take a look at this picture. The increased deposits cause an osmotic edema and a fluid collection that is associated with a generalized non-pitting edema. So look at this picture, like this guy, like I have bags under my eyes, but look at this guy. This is crazy. He looks like he has balloons under his eyes, right? You can also have cardiac alterations secondary to myxodematous changes, which include decreased contractility, cardiac enlargement, pericardial effusions, decreased pulse, decreased cardiac output. You can also see decreased GI activity. So this leads to like constipation and abdominal distension. There's skin changes, like all sorts of stuff. Hair becomes thin and fragile, and there can be even like just hair loss. So all sorts of stuff can go on. And again, this is a complication of hypothyroidism. Let's see. All right. Don't We also worry about hypoglycemia and hyponatremia related to this. And then, of course, you're going to have all the signs and symptoms that go along with both of those. This is slide 7. So this just shows like tertiary, secondary, primary, where the thyroid gland is, pituitary gland, and hypothalamus. This slide 8 is a slide of the myxedema, just the signs and symptoms that you will see. Slide 9, we have some safety alerts. In patients with a history of cardiovascular disease, increases in dosage of levothyroxine are made cautiously because sudden increases in cardiac rate and contractility secondary to the medication may lead to angina or congestive heart failure. And then patients with hypothyroidism who are receiving sedatives, hypnotics, or narcotics require close observation because the metabolism of the med is slower and respiratory compromise may occur with normal dosage. The dose, as well as the interval between doses, may need to be adjusted in the patient with severe hypothyroidism. That bottom one really has like NCLEX written all over it to me. It really does. Seems like a big one. So hypothyroidism RN considerations. So obviously we're going to look at O2, because severe hypothyroidism can impair respiratory function, which obviously could lead to O2. Our person likely has a decreased body temperature, but we want to look at heart rate, blood pressure, respiratory rate, etc., all secondary to that hypometabolic state, right? Everything is slowed down. Serum calcium levels. If somebody with hypothyroidism, okay, goes in and has like a surgical resection or removal of the thyroid, or there's damage or removal of the parathyroid, this obviously can lead to decreased serum calcium, right? Which we talked about back related to electrolytes and whatnot. We also worry about daily weights. If everything is slowed way down metabolically, we worry about our person gaining a lot of weight. We expect their skin texture, color, and turgor, skin to be kind of dry, myxedema, right? The skin just does not look healthy. Bowel elimination, we had talked about constipation related to decreased GI motility. So our actions is going to be give that thyroid medication, right? Give the Synthroid. Same time every day, talk to your patient about it. Give Synthroid specifically is given in the morning, 30 minutes before you eat. And then we just talked about giving narcotics and sedatives with caution because of that decreased metabolic rate. Maybe warming blankets because of their cold, right? And they have cold intolerance on top of that. So you may want to use warming blankets. You do worry though about, this is so crazy, but if you warm them up too quickly, you can have vasodilation, like really quick vasodilation, which can lead to hypotension. Okay. So we even have to be slow about warming our person up. We do worry about skin integrity and all of that. And we talked about teaching. Um, Teaching also involves monitoring for cardiovascular signs and symptoms because you can end up with cardiovascular disorders related to hypothyroidism. All right, hyperthyroidism. Okay, hyperthyroidism. If you're looking at this slide, this is slide 11. Look at those eyeballs popping out. Exopopophthalmus. I don't know that I'm saying that correctly, but all right. So hyperthyroidism can present at any age, most commonly diagnosed in females between 20 to 40. Um, Let's see. Graves' disease is most common cause of hyperthyroidism and is an autoimmune disorder involving antibodies, thyroid stimulating immunoglobulins, and remember, immunoglobulins is just antibodies that bind to the thyroid gland, resulting in the enlargement of the thyroid gland and subsequent hypersecretion of thyroid hormone. So Graves' disease causes these antibodies to basically attack the thyroid, right? And then in attacking the thyroid, it releases more thyroid hormones, and so you end up now, like with hypothyroidism, where everything was slowed down, and hyperthyroidism, you have accelerated metabolic symptoms. Okay, so it's going to be the opposite. You don't have to memorize both. Just think about what is happening in one, and then you're going to know what is happening in the other because it's the opposite. Okay, so you are going to have excess T3 and T4 from the thyroid gland. There may be increased thyroid stimulating hormone from the anterior posterior gland. Um, and then, of course, tertiary, you can have thyroid releasing hormone from the hypothalamus. So, again, we're talking about which gland is really the problem child, right? Because that's going to determine which hormones are being released and what signs and symptoms we're going to see. So the increase in metabolic rate can result in an elevated heart rate, dysrhythmias, increased heart sounds. You can end up with bruits, like a thyroid bruit, because you've got all this increased blood flow, right? So now you've got increased blood flow all trying to squeeze through this area. Now we have heat intolerance, okay? With hypothyroidism, we had cold intolerance. Guess what? We're the opposite, heat intolerance. Now we have increased gastric emptying, increased appetite. We're going to have increased appetite, but we're going to have weight loss with this, okay? Um, Nervousness, insomnia, we do have hair loss with this also, okay? Exophthalmus, that's protrusion of the eyeball. You can have a goiter with this. You can end up with visual changes. Okay. Lab findings, we're going to have elevated T3, T4, but decreased TSH in primary disorders. And remember, that is because the TSH comes from the pituitary gland. Okay. So a primary disorder means that it is the thyroid itself that has the problem. So that's just going to be T3 and T4. That TSH comes from the pituitary. So if nothing's wrong with the pituitary, TSH is going to be fine. Okay, that's going to be okay. Our problem is going to be looking at that T3 and T4. We may have antibodies to TSH related to Graves' disease, okay, which is super interesting. And that's about it. So treatment, we want to control that hypermetabolic state, okay? Although there are specific pharmacological agents used in the treatment of hyperthyroidism, the management of clinical manifestations, particularly in relation to cardiac function and body temp, is the priority. So non-surgical treatment focuses on ensuring adequate fluid intake because insensible losses are greater secondary to the hypermetabolic state. monitoring for CV complications and promoting a quiet, non-stressful environment are important. Pharmacological agents also may be used for symptom management, maybe beta adrenergic blocking agents, because they're going to slow the heart rate, decrease palpitations. Meds for long-term hyperthyroidism. There are anti-thyroid meds, okay? There's some names here. Let's see. There's some names here that you, at least on this test, are not being tested on. These meds reduce clinical manifestations of hyperthyroidism by interfering either with the formation or release of thyroid hormone. So for short-term management, we may use iodine preparations, okay? Particularly to patients before a thyroidectomy to decrease blood flow through the thyroid gland in order to decrease thyroid hormone release. Table 43.3 gives a nice overview of all the meds related to hyperthyroidism. And also box 43.1 talks about precautions for patients using radioiodine. This is slide 13. This is just showing like a normal thyroid and then an enlarged thyroid, holy cow, what a goiter looks like and what exopithalamus looks like. And those are those poppy eyeballs. Slide 14. These are our safety alerts. So safety alert number 1, patients with hyperthyroidism require close monitoring of their fluid and electrolyte status because the hypermetabolic state increases insensible water loss through perspiration as well as elevated metabolic rate. Okay, when we talked about that. Safety alert number 2, in the inpatient setting, if a patient receives radioiodine for treatment of hyperthyroidism or thyroid cancer, the following precautions are needed. So the patient needs to be in a private room. You need to have a caution sign, radioactive material on, place that on the door so that anybody entering that room is aware. Nursing staff wear a dosimeter badge at all times when interacting with the patient to measure amount of exposure to the radioactive material. Staff are to limit direct contact with patients to 30 minutes per 8-hour shift. Staff are rotated to minimize radiation exposure, and pregnant staff are not to be assigned patients receiving radioiodine therapy. Encourage patients to complete as much of their care as tolerated. Slide 15 here. This is another one, precautions for patients treated with radioiodine. They should be at least 6 feet of separation from another adult, basically, so that that would apply to like if you have to cohort people, if they have to sleep in the same room, they need to be at least 6 feet apart. Delay return to work for 1 to 5 days. Maximize distance from children and pregnant women at least 6 feet for 1 to 5 days. Limit time in public places 1 to 3 days. Do not travel 1 to 3 days. Do not do a prolonged automobile trip with others for 2 to 3 days, because basically you're exposing all these, this is all about exposure to radioactivity, right? Maintain prudent distance from others. This seems to be about 6 feet is what is decided upon. Drinking plenty of fluids for 2 to 3 days. That is going to help the body flush out the radioactive iodine, okay? Don't prepare food for others, okay? You can contaminate it. Don't share utensils. Sit to urinate and flush the toilet 2 to 3 times for 2 to 3 days after administration. I actually remember learning that in school. And the whole like sitting to urinate is so that you don't spray radioactive pee around the bathroom and then somebody else comes in contact with it. Do not sleep with a pregnant partner, child, or infant. You know, this says 6 feet of separation, but holy cow, right? All right, so thyroidectomy considerations. All right, so if the thyroid is just overproducing and overproducing and overproducing, they may actually have to remove the thyroid. So now there's a lot of post-op considerations related to the thyroid because of where the thyroid is located. So if we go in and do a surgery and remove that thyroid, we absolutely worry about airway. We worry about hemorrhage. We worry about hypocalcemia. Um, if all of that parathyroid was taken. We worry about damage to the laryngeal nerve. Um, so hemorrhage is most likely within the first 24 hours. So you need to look for bleeding around the dressing, also down the back of the neck. I remember learning in school, one of the things you monitor for is like people excessively swallowing because that can indicate that they have drainage down the back of the neck. And maybe that blood is not coming forward. Maybe that blood is not presenting on the dressing, right? Maybe it is just running down the back of the neck. So you assess for swallowing with that. They can actually use sandbags to kind of help keep the head in proper alignment. And this is to prevent tension on the suture site. Okay, so like basically relieving that tension on the neck. Post-op, we're going to put our patient in a semi-Fowler's position. That's going to help ease work of breathing, decrease risk of aspiration. We're going to give humidified air. That's going to help with secretions. Always make sure you have suction equipment at the bedside. And we are going to make sure that we have a trach tray ready to go. If this person has swelling or hemorrhage or something like that, we do risk losing that airway. So you're going to have all these things bedside. Now, keep in mind, we can't orally intubate relate because of this surgery. We're going to need to do a trach, right? We're going to need to go below the site. So that's why you have the trach tray at the bedside. Um, let's see. Tetany can develop secondary to hypocalcemia. Remember, that's like the intermittent muscle spasms, tetany, because calcium is using usually calming. But this can be result of damage to the parathyroid glands. So you end up with hypocalcemia. Again, make sure you have suctioning. Assess for damage to the laryngeal nerve. Changes in voice quality, particularly hoarseness or a husky tone, can be indicative of laryngeal nerve damage. Maybe that's my problem. Maybe I have laryngeal nerve damage. Voice assessments are conducted every 1 to 2 hours in the immediate post-op period to monitor for changes. Okay. So there's a lot of post-op things related to a thyroidectomy. All right, so hyperthyroidism. Now our RN considerations. So we're going to do vitals, obviously, right? We're going to worry about eyes and nose. We're going to, assess those eyes. Are they popping out? Are they bulgy? How is their vision? What is their T3 and T4? Do they have a goiter? Are we worried about seizures? Are we worried about their weight? Meds. We talked about meds, right? The radioactive iodine. Um, let's see. Mm, Oh, they may have dry eye related. It's the disease process itself, but also when they have the hypothalamus, maybe that eye is not getting covered all the way, and you can end up with dry eye, and so we can use lubricant for that. Teaching going to be related to disease process, going to be related to those medications. Now remember, if we are treating for hyper, we have to educate the person about the signs and symptoms of hypo, because with treatment, we can always tip the person the other direction. Okay. So they have to be aware of both signs and symptoms. We want to make sure our person is consuming adequate calories, basically just to maintain weight. All right, so thyroid cancer. Thyroid cancer usually presents with a nodule on the thyroid gland. Most common is endocrine. It's the most common endocrine cancer. Sorry. Risk. Your risk is neck exposure to radiation as a child. Okay, so I honestly, I really think about x-rays. I had asthma as a kid and always had x-rays like all the freaking time, right? And so I think about those, little kids who are having x-rays all the time related to whatever it may be. And then also there's family history. So treatment, maybe a thyroidectomy, maybe radioactive iodine, and it's a cancer, so maybe some chemo. Remember, with thyroidectomy, then a patient's going to have to be on levothyroxine or Synthroid for life, okay? Because now that if the thyroid's gone, we need a replacement. So signs and symptoms, you're probably going to note nodules. Maybe there's hoarseness, maybe there's dysphagia, okay? Diagnostics. They're going to do a fine needle aspiration biopsy, maybe an ultrasound, and maybe some radioactive imaging. Thyroid cancer considerations. Again, because of where the thyroid is located, think airway. All right, we're always going to be worried about that. We're going to worry about vitals related to low thyroid, nodules, TSH levels, calcium, actions, meds as ordered, and then, of course, all the post-op care. Teaching is disease management. Signs and symptoms of hypothyroidism now that the tumor is removed. Okay. And then follow up. Make sure you're following up and make sure you're taking your Synthroid as prescribed. All right, hypoparathyroidism. So now we're doing hypoparathyroidism. So this may be related to removal of the thyroid. It could be autoimmune or it could be idiopathic, meaning we just don't know why, right? So the pathophysiology, really the hypocalcemia is going to be the primary disorder. Okay, that is what we're going to see, the signs and symptoms. That's how it's going to present. That's what we're going to notice. So when you're thinking signs and symptoms, think of those hypocalcemia signs and symptoms. And that, that's your Chavostex, your Trousseau's. Remember all that, the twitching, the tingling. Okay. Diagnosis, low calcium levels, and then high phosphate. So I know when we talked electrolytes, we kind of said nobody cares about phosphate. And that's pretty true, because really the only reason we care about phosphate is due to its relationship with calcium. So it's like calcium is the famous person and phosphate is just the hanger on. Okay. So calcium and phosphate have an inverse relationship to each other. And the body uses phosphate to balance high calcium. Okay. So if I have high calcium, what the body is actually going to do is use phosphate to bind to the calcium. So the calcium, we can also use like calcitonin and stuff that pulls that calcium back into bones. It helps the kidneys release it more. You get less GI absorption with it, right? So with low calcium, with hypoparathyroidism, because they're an inverse relationship, I'm going to end up with high phosphate. And it's not that I really care about high phosphate, but to balance the low calcium, what the body is going to start to do is pull calcium from our bones to get that phosphorus back into an equal homeostasis level. Okay. And so think about when the body starts pulling calcium out of bones, your bones get weak. You have free floating calcium, which then puts you at greater risk for kidney stones. And also, it's, calcium's a big old fat thing. We don't need it floating around the bloodstream because you can end up with obstructions. Okay. So, so just remember when we talk about phosphate or phosphorus, whatever state it happens to be in, the only reason we care is because of its influence on calcium. Okay. So treatment with hypoparathyroidism is totally focused on raising those calcium levels. Slide 21 is just a nice diagram of that cascade, okay, related to calcium and how the body responds. And, don't forget that in all this calcium phosphorus talk, that we can't even metabolize calcium if we don't have enough vitamin D, okay? So now we have a thruple related to this, right? So you got to think about what all three of those things are up to. Slide number 22 is just a review of Chavostex and Trousseau's related to hypocalcemia. Also remember, you can get that circumoral tingling. I apologize. The circumoral tingling is that tingling around the mouth, okay, that you can see with hypocalcemia. RN considerations, assessments, vitals, cardiac monitoring, right? Calcium levels, acid base status, neuromuscular, because remember, with low calcium, you get all that twitching, tingling, the tetany, all of that stuff, right? So actions, calcium supplementation, but it has to be with vitamin D, otherwise we can't metabolize it. Teaching is going to be related to lifelong calcium supplements, taking food that is high in calcium but low in phosphorus. Because if you go and ingest a bunch of phosphorus, you are counteracting whatever you're doing to increase your calcium. Okay. And then we want our people to be aware of signs and symptoms of hypo and hypercalcemia. This is just a slide 24, of some high calcium foods. Calcium and vitamin D fortified, like orange juice, which would be good. Rhubarb, figs, dark green leafy veggies. This is like your collard greens, your yucky kale, mustard spinach, and soy products are actually good. Hyperparathyroidism, most often related to adenomas, so cancers, tumors, okay? And secondary disorders are often related to renal disease. So the pathophys on this, it does cause hypercalcemia. So now we have hypercalcemia, which means you're going to end up in bone demineralization, because more calcium in serum in the blood means that there is less calcium being reabsorbed into the bones. Okay. Like we talked about, anytime you have extra calcium floating around, you are also at risk for kidney stones. We don't like it floating around in the blood. It's kind of big and fat and can cause obstructions. So our signs and symptoms are going to be related to that hypercalcemia. Okay. Remember, constipation can be related to hypercalcemia. You may have cardiac changes. This can even cause peptic ulcer disease, polyuria, anorexia, small a, so you just don't feel like eating. So those are your signs and symptoms. Diagnosis, we're going to look at our PTH levels and our calcium levels. Treatment, we want to lower that calcium. We want to increase PO fluids because, again, if we can flush things out, that is helpful. They may be on normal saline infusion. And then these guys, we want them to avoid calcium-rich foods and vitamin D. Because if they can be vitamin D deficient, basically, then the body's not even going to be able to absorb whatever calcium is floating around anyway, right? So we don't want them taking in vitamin D. Also, we need them to think about avoiding diuretics that increase reabsorption of calcium in the kidneys. So a lot of dietary stuff. But again, it's the opposite of hypo. Okay. So if you can remember one, just flip it and you can remember the other. So our RN considerations, it's all about that calcium and that phosphorus. Okay. Cardiac monitoring, acid-base status. We want our person to be drinking or intaking at least 2 to 3 liters per day of fluid to help flush, maybe even diuretics for this, right? And we may give them PO phosphate because I know if I give you PO phosphate, it is going to bind to that calcium and help get that calcium out of the body. Okay. Um, we worry, so you've got to remember if there is extra calcium floating around in the blood, that means some of that calcium could have been pulled from the bones. So the bones may be weak. So we need to make sure that we are careful, that when moving people, we take care not to cause bone injuries related to this. And then don't forget that, we're talking kidney stone potential. And so you may actually be like straining urine and stuff like that if we're thinking they may have kidney stones, renal calculi, right? Teaching hypo and hyper, signs of low calcium, signs of high calcium, and then dietary considerations, fluid intake. Remember when we're talking hyper and we're trying to flush things, ideally it is that 2 to 3 liters per day. There we go.